Our UVC light will give us these breakthrough decreases in surgical site, and really the specific focus of this talk is on prosthetic joint infections, which is a huge issue, very frequent surgical procedure to be done. It targets the primary source, which is the air in the operating room, and administers safe and continuous disinfection. Infectious particles are traveling through the air on their way either to the surgical site or to the different instruments, implements, or even worst case scenario, the actual implants themselves, which are going to be then going into and making contact with the wound. Between 2 to 5 times more likely to have mortality in this patient population that gets these infections. These operating room UV disinfection robots that would come in between our cases, and they would roll around and everybody'd have to leave. They'd put up all the signs on the windows, danger, no one enter. If we can really just use an invisible light to shine, and wherever we shine, it kills effectively all of the infectious particles, that seems like that should be a game changer. That's $1.5 million in cost yearly just from this one set of surgeries in their operating rooms, which is just enormous. But despite all this effort that's put in by everyone in the ORs and in the administration of hospitals, they're punished financially for these infections when they occur, for these invisible enemies that they're literally doing everything they can. The operating room air isn't that much more sterile than what's on the wards of the hospital. So it's still got bacteria. We just try to keep it as minimal as we can. Now, how do those bacteria get into the air? One, outside air has a higher concentration. You open the doors and it comes. Additionally, the people who then walk in as well bring with them skin and dead skin cells, always sloughing off 1,000 squames per person per minute, with roughly around 10% of those carrying some bacterial particles and infectious matter. Additionally, they all breathe. At least some of it is going to go around masks, and no matter what hood system you use, some is still getting someplace in that room. Additionally, anything that lands on the floor subsequently by foot traffic gets kicked up. Even if it was really clean before you started that operation, that is one of the other major sources of bacteria making its way into the air. So the airborne concentrations have a direct correlation with the number of people in the OR. Each 20-minute increase in operative time was associated with nearly a 25% increased risk of subsequent joint infection. The exposure to infectious particles, whether it be bacterial, viral, what have you, that the more of them you get exposed to, the more likely you get infected, the more likely you get a severe infection, and or the more likely that you actually die from that infection. So this is actually looking at mortality in that last curve you see there. The increased exposure risk is because of the fact that you always have constant release of microbes into the operating room air. It increases the bacteria that will reach the surgical site directly via the air or indirectly via those gloves, instruments, and implants. Now, increasing the wound exposure, whether it be larger incisions and or longer surgeries, is another big time risk factor, and that there being a heart surgery reference, as you see in that picture. And also, if those bacteria then fall into or get into a space that doesn't have very good host defenses, like the cerebrospinal fluid, for example, during neurosurgery, things like that, we don't have a lot of very little to none white blood cells in those spaces, and so they become a lot more likely to get infected when those particles do reach those areas. And also, as we've mentioned before, implanted materials. And why is that? So for these total joints, for instance, but it applies to multiple different surgical types. And also the last category is transplant patients, which is really another big one, unrelated to our discussion, but you're talking about, for instance, with a liver transplant, you're talking sometimes between a 6 and 12-hour surgery with a very large open incision and a patient who's going to be severely immunocompromised from their original illness and from the immunosuppressants. It's not a surprise at all then that we have roughly a 10% infection rate in those patients post-operatively, which can be quite devastating. So if you are exposed to less bacteria, in this case less airborne bacteria, for our purposes, less surgical site infections and prosthetic joint infections will occur. Sterile setup table in the operating room is not so sterile. This 2023 study, all of our new techniques and advances, the contamination rate for these sterile setup tables was 12.5% of them, also known as back tables. So a very significant amount for what is supposed to be the most sterile thing. There's no break-in technique necessary. This is everything being done right. Simply having a laminar airflow system in place will not provide bacteria-free conditions at the surgical site or at the instrument or sterile setup table. When you try to control the air, you're effectively just trying to manage the chaos a bit better. It does dilute it, but you can't direct all those particles and predict where they land, and or have them not land anywhere and make it into an exhaust vent. You will never be able to eliminate the presence of airborne bacteria. It's going to be in the air. These conflicting studies on ventilation systems is actually the true answer. We can keep modeling studies differently, but they will keep coming up with these same, sometimes contradictory results that never pull too far from the baseline of either or. That's because of this error and the lack of predictability, even under incredibly controlled OR conditions. And the only way to decrease this risk, 1.5% or so for these prosthetic joint infections, is to kill those unavoidable bacteria in the air before they predictably land on in the surgical site or on those different instruments and implants. And that's where FAR-UVC comes in, to give you those breakthrough decreases in surgical site infections. It's targeting that primary source in real time, that operating room air, and administering safe and continuous disinfection. You're getting predictable continuous disinfection from FAR-UVC against unavoidable continuous contamination. The number one cause of surgical site infections worldwide is Staph aureus. The FAR-UVC continuously killed over 98% of that Staph aureus in the air, even while they were continuously blowing it into the room. Problem meets solution. Continuous release of contaminants into the air in the operating room, including Staph aureus being one of the most common, meets continuous disinfection in real time, safely. Less airborne bacteria equals less surgical site and prosthetic joint infections. Here's what this looks like. Going back to that study again, what you have in FAR-UVC is reversing the exposure response curve by driving the risk down that disinfection response curve. And you see the similarities here when you look side by side. And in fact, it's even more stark over here. Now, we're talking apples to elephants, but the same concept is here and applies. And when you drive down anything 98%, you're basically just talking about speeding this up. Controlling with FAR-UVC light disinfection is going to involve, primarily just shadows, which is fairly predictable. And those variation, those shadows and that airflow, because it has to be exposed to the light for a certain amount of time, is accounted for by using high fluence rates, basically brightness levels, and then installing those lights at different angles throughout the operating room. With air particle transport and ventilation systems, even running 150 air exchange per hour rates, sometimes you actually can get higher levels of infection from kicking up these particles too much. But you're going to have highly variable results regardless. And with UV light disinfection, you're going to have a proven and consistent decrease in surgical site and prosthetic joint infections. But Duke still to this day uses it to decrease their surgical site infections. And some of the biggest things to jump out at you here is these decreased percentage of infections. Now, these studies did, in fairness, start in 1940, but they also go up through studies in 2007. When they turned the lights off, they had a 5% infection rate, and then afterwards, 0.5, 90% decrease. This overall average reduction of surgical site infections was 80%. That is just absolutely phenomenal. We have equivalent doses already well established in the literature. We've already got scientific studies that have all been done on this. So we know basically the amount or brightness and the exposure that needs to happen for the same bacterial types to be killed by FAR-UVC as compared to the other mercury-based 254 UVC. FAR-UVC is equally effective against nearly all pathogens. In fact, it's more effective against many. And we can also use a lot more of it because it's safe for human exposure. We established that less airborne bacteria equals less surgical site infections and joint infections. And in this case, wait a minute, 2/3 are seated in the operating room from the air in the operating room. What was our decrease again? Now looking again at that bedrock scientific principle, if you drive down the disinfection response curve, you can kill those bacteria in the air. What's going to follow? Using UVC, real-time disinfection, no surprise, had a 68% decrease in that study in 2007 over 19 years and 6,000 patients. This is fairly predictable, actually. This is where that problem meets solution just fits perfectly. You've got no injury risk, inactivation of pathogens, surface, etc. No turnover time problems, and also that real-time air disinfection, which is what we need to drive this down, to get that breakthrough. And you're going to get, some years of use out of these things. And as far as operating costs, use about as much energy as an LED light bulb. Not only we got long-term studies, also extreme exposure studies have been done as well. So we've done this in albino mice, we've done this in people with sensitive skin types, but it's never been able to harm a human or an animal when you use filtered FAR-UVC, which is what is all on the market effectively. It's in fact much safer than sunlight, and that's not an exaggeration. And this is from the Boeing aerospace engineer team that's been working on FAR-UV see technology since 2015 and put it on their showcase airplane, the worldwide showcase airplane, which is called their Echo Demonstrator in both 2019 and in 2022. They basically did the calculation, said that skin cancer risk is less than 1 in a quadrillion. So we'll just call that zero. I don't think that's a stretch. It's only theoretical, not even there. For UVC, give us an opportunity to have real-time disinfection of the air and real-time disinfection of the surfaces and the area around the surgical field as well, and everything that goes into it. Destroys the most common bacteria, just as one example, with ease, and over 98% continuously, even when you intentionally blow it into a room. And all others as well. This will decrease surgical site infections and these prosthetic joint infections, better patient outcomes, and it has all the benefits of the other UV applications in the OR, but without any of the drawbacks. Safe for exposure to humans. There's no risks, hassles, compliance burdens to the patients or to the OR personnel. No impact on OR efficiency or turnover times. Predictable, continuous disinfection against unavoidable continuous contamination. Using those bedrock scientific principles, exposure response curves, and the corresponding disinfection response curves to lessen the airborne bacteria and lessen those surgical site and prosthetic joint infections.